The broadcast is now starting. All attendees are in listen-only mode.
Thank you, everyone, for joining us for another Learning Lunch hosted by FormatApproved.com. My name is Brian Johnson. I'm the Senior Director of Online Training and Education with ForMed Training, and I'll be your moderator today. Today's Learning Lunch will cover understanding value-based plans, pay for performance, and ACOs. We are joined today by Greg Gootee, Product Manager for MZI Healthcare, a software vendor that provides analytic and care management tools for payers, hospitals, and providers. Greg has many years of experience in health IT, and we are honored to have the opportunity to share his expertise with you today. Before we begin, please note that you can ask questions of our presenter at any time during today's session by entering them into the chat area during the presentation. In the second half of our session, we will address as many questions as time allows. If we do run out of time, answers to all submitted questions will be posted to our website and sent via email link later in the week. Also, please note that all registered attendees of today's session will receive an email with links to both the recorded and PDF versions of the event. All right, Greg, well, thank you for joining us today.
Thanks, I'm glad to be here.
All right, so bear with me for just a moment. All right, so first, let's begin. What's different about value-based pay for performance versus traditional programs?
Well, there's a lot of changes going on today in the industry, and I'm sure all of our listeners today are well aware of some of those. But really, the past traditional programs that are out there were really focused around controlling utilization and cost reduction. And traditionally, you'd see a lot of HMO, PPO that had started many of the programs that are out today. And some of the other ones, such as capitation, different gain sharing, withholds and bonuses, were all different types of programs that are out there today. But it's really changing, and with the triple aims and healthcare reform, the goal really is to focus now on clinical quality, more efficiency within hospitals and provider groups, and really keying in on the patient satisfaction.
That's my take on it, is that there's a lot of interest in this because I think everyone has the sense that things are headed in this direction generally, but there's also a lot of confusion and a lot of questions about it. So I think many of our listeners will be excited to learn more about these programs. So how are these value-based performance awards determined then?
Well, you know, the traditional things that are out there now, and even some of the new programs, are really focused around the financial area, in bonus programs or secondary incomes, you know, the shared savings with accountable care organizations, and the bundled payments that CMS has out now. But there are some other ways that these programs are being incorporated, and a couple of those are really in public recognition, so provider groups that have reached or achieved different levels. You know, you have the Patient-Centered Medical Home with NCQA and other programs that are out there. And then also some focus around patient switching to move patients to providers that may have better performance scores. If you think about Medicare Advantage programs and the star rating, that's really kind of CMS's goal there, is to provide transparency to Medicare beneficiaries and allow them to focus or move to programs that seem to have better quality and better outcomes.
All right, so as people move in this direction, what are the analytical and information systems they need for doing value-based purchasing?
Well, you know, I think a lot of groups really lack in this area. This is in healthcare in general. You know, IT has really taken off here in the last few years, mainly because of some of the incentive programs that the government has put in for EMRs and EHR systems. But when it comes to the analytic pieces, and we start trying to understand how some of these new payment programs will be designed and how providers can renegotiate contracts while demonstrating, you know, outcomes and efficiencies that they have, the systems need to be a lot more intelligent. And I think we've moved away from the ability where, before maybe we could show some things through Excel or some simple tools. The type of work that needs to be done now is some really deep diving, understanding your population health and your population that you serve and what the risk within that population is. And I think that the tools that are out there today are rapidly changing. And some of the things that we're seeing is secure communications with providers and patients, the ability to understand and evaluate risk better, and stratify those populations that you serve.
So you're talking about these analytical tools. I wonder if you could just tell us a little bit more, and I know we're going to continue on with the other slides, but so you're saying that in the past it was sort of straightforward, but now there's this sort of big data. You really need better tools to be able to track value-based performance.
Absolutely. I think when we talk, you just mentioned a key term is big data. In IT, where the era that we're really entering is kind of the big data era. There's not only in healthcare, but all the other industries that are using big data to find out new trends. And I think that's where we are today, is that there's a lot of things that we've never really understood very well about our patients. And being able to bring data from different sources, such as labs, pharmacy, the claims data, and other information from both providers, hospitals, and patients, allow us to really do a deep dive and find trends that maybe we never realized before. And I think the tools that analyze that data, are a lot more sophisticated than most groups and provider organizations have been used to in the past. On some of the large health plans, Blue Cross and Aetna and some of the other ones had some of these tools, and really it was one-sided. So the payers had a lot of information providers never knew, and that information really wasn't shared very well. As we go forward, it's really going to be key that both providers and hospitals have access to that type of level of understanding of their patient, understanding of risk, so that they can better contract. Because I think margins, I think we all know margins are getting very small, and to meet the triple aim, there's a lot of better understanding that we're going to need to know.
So what types of legal barriers are there to value-based purchasing?
Well, this is a really key area, and we'll talk a little bit later about, what do we do, how do we get ready for some of the programs that are coming out. But in many cases, the contractual obligations that providers and hospitals have today really don't include some of the items that, as we move forward with this value-based purchasing, will need to be included. So a lot of times those two don't intersect, and I think it's very important that people understand that they need to reevaluate all their contracts as they enter into these agreements. Typically, a lot of times these pay-for-performance items aren't even included in the contract, and these are areas that can be of concern to the provider. There's a lot of key things that they need to consider when they look at different legal barriers, such as how the data that they're being paid on, what is the integrity of that data, and my referral patterns, how do they play a role in that, along with malpractice issues. So I think there's a lot of issues that need to be really thought out carefully before you enter into these types of agreements.
When you speak of integrity of data, can you tell us a little bit more about what you mean by that?
Yeah, I'll give you a very simple example, and that is, if you think about, let's just pick a quality measure. Let's say body mass index. So when you go to a physician's office, every time that you see the physician, they get your weight, your height, and they really calculate your BMI. But on a lot of the information that's transmitted via claims, that information is not documented, and thus your score would be much lower by looking at administrative data only. So when we look at the integrity of the data, understanding that we're getting complete data, that there's a way, I think providers need to be in control of being able to change that data. And if I had a patient that went to Walgreens and got their flu shot, then I need to be able to record that and get credit for that. So I think these are all little things that add up to a big problem if they're not taken into consideration.
Yeah, I see the potential complications. I mean, it must be really there's so many details to keep track of that I think people haven't thought in these terms in the past. I want to follow up on the malpractice issues. I'm sure that's a whole can of worms, but can you just give us a brief portrait of what are some of the considerations involved there? How would that change under value-based?
Well, I think, as we move into more evidence-based guidelines, making sure that those items that we've agreed upon and those evidence-based guidelines are in line with truly what the practitioner delivers in care. I think that, as we start documenting more and understanding the variance in care in different regions, I think malpractice issues will become more evident.
Right.
And
so
I
you've got evidence-based standards, and then I'm sorry, go on.
Right. I was just going to say, and having that information included in your contractual agreement so that it's very clear what you're agreeing to up front.
So how soon should we expect to see value-based purchasing? It's something that a lot of people are talking about, but where is it on the horizon?
Well, I think there's a lot of movement in this area, and you started out at the beginning talking about there's lots of confusion in the marketplace, and I would totally agree with that statement. And I think it's kind of like a double-edged sword. CMS really being the leader in some of the initiatives that are starting to change the market has tried to, instead of coming out with a set of rules and saying this is how we're going to do business, they really open it up to allow different organizations to try different things. And so there's a lot of different things happening currently. If you think about California, they've been doing P4P for a long time, but once again, it's really been focused around controlling costs and reducing utilization. And now, there's a big initiative to really look at value-based P4P, where now we're focusing on quality and outcomes, experience, and some other items. ACOs are really getting underway. There's been a lot sign up there, so we see value-based purchasing in the way that they're doing business and conducting that. And then we have the new hospital value-based purchasing, which is the CMS initiative, really changing the way that a hospital business is done. And so there's a lot of different avenues coming, really things happening in different directions. But value-based purchasing is really here today, I believe, and it's only going to increase in how rapid things start changing. In healthcare, I think we're going to see some rapid change over the next 3 to 5 years in both payment and purchasing around this value-based purchasing.
So what's at stake then under value-based purchasing?
Well, I think, we talked a little bit about contractual issues there, but, here's an example. If we think about how the new hospital CMS value-based purchasing is being done, it's totally self-funded by the hospital contributions. So you can see a 1% reduction in 2013 and then increasing each year thereafter with a 2% reduction in 2017 and beyond to help fund these initiatives. I think what you're going to see in most all of these programs is really funds being redistributed in different ways. And there's going to be winners and there's going to be losers, unfortunately, or those that kind of have a break even. One of the upcoming trends is really looking at also efficiency measures. For an example, on hospitals for 90-day post-care. So these initiatives that are here today with CMS are going to start affecting providers and other organizations, not just the hospital, with the design of the care that they're undertaking.
So to be clear, the hospital, those efficiency measures for hospitals are already in place through CMS. Isn't that correct?
That is correct. It started the end of 2012, and further pieces of the regulation will kick in effect here at the end of 2013 and for 2014.
And is there already legislation or regulation in place to expand that, or is it just part of the overall trend that it's going to spread out from hospitals to other providers?
No, there are other things that are in the works to expand upon that. We've got the bundled payment initiatives that are going on, and a lot of the commercial. CMS is really taking the lead and driving the industry, I think. But we're seeing a lot of move now on the commercial side to also change the way that we're paying. And so I think this will rapidly change, and it's going to affect the way that business is done within the organization.
So then what are some key items providers need to be successful in value-based purchasing?
Well, I think, you need to kind of understand what types of data that you're going to need to require. And, there's been a very good movement on EHRs and be able to get that data in electronic format, which will definitely help. But a lot of provider groups that we work with, and even hospitals, just don't have the IT resources or capabilities to move as rapidly as things are moving. So I think that's going to be an area of concern and definitely something that needs to be addressed at your organization. And then, change, nobody likes change. And you need to really assess whether your organization is ready for some of the changes that are coming and how do you move your organization to that level. If you think about, some of the changes that have come already and how that's transformed your office. When I worked with the IPA, we put electronic health records in, and one of the things that we noted was that, if there were any problems within the workflow of the office, when we added that technology, we definitely magnified those problems. So an organization really needs to kind of do a self-evaluation of that. And this has to come from the leadership. This really needs to be derived from the leadership within the practice and an evaluation of what the financial impact on your organization really needs to be gone through.
So when you talk about IT capabilities, I mean, obviously EHR solutions would be part of that. Are these largely software capabilities that we're talking about rather than hardware? Or is it a combination?
Well, I would say typically the majority would be software, but when we start talking about bringing all this data together, you end up with large volume of data, and there's, when we talked about like data integrity, storing that data, keeping it safe, and providing the type of power really to do different types of analytical work and understanding that financial modeling of some of your data takes more resources. And so, I mean, I think hardware is also a concern, and understanding, I know how many provider groups that we used to work with that had a computer under Susie's desk, and that was their server, and there was really no protection for it, and maybe they did a backup once a week, and it went in someone's purse, and they went down the street with it home. So there's a lot of areas that really need to be evaluated: how you protect the data, how you can be ready when more data is needed, and you start taking in and trying to analyze that data. So I would say it's predominantly software, but there are some hardware issues.
Yeah, that makes a lot of sense. I just want to, before we move on, I just want to remind our attendees that we'll send out a follow-up email with the slides of this presentation, along with a copy that you can view again if you'd like to share it with colleagues. And also, you can ask questions at any time of our presenter. We will, at the end of this session, we'll go ahead and ask your questions of him, but you can type them now if you'd like, and we will ask them at the end of the session. All right, let's continue. So what are some of the pitfalls? I'm sure there's concerns that people should take into consideration. What are some of the things they should keep in mind?
Well, really understanding how measures and objectives for your organization, do they fit with what your organization's strategic goals are? What is the cost of getting data that you may not currently have? And that's really a big issue. Data acquisition right now is a major concern with every organization that we work with, and there is a high cost with different vendors. For example, a simple continuity of care document exchange for some electronic health care vendors can cost you around $1,500, and then some monthly maintenance up to $30,000. So there's a large variation in data acquisition, and we're working with a lot of organizations that really struggle with multiple providers with different EMRs, and some that just plain don't have an interoperability option. So getting that that data so that as an organization or a group, you can really get the right information at the right time is critical, and the cost of getting that data can be pretty spendy right now. There's going to be a lot of competition, and one thing that, the goal of this is not to create competition that creates uncoordinated efforts. The whole goal really is to have coordinated care across the continuum for a patient. And I think there can be inappropriate incentives, and I think as an organization you need to know what your ethically obligations there are. And, the patient plays a big role in this. So, we're starting to look at outcomes and understand outcomes and be judged or paid based on those outcomes, and without involving the patient to really try to change patient behavior, it's just not going to work. And then, of course, you always have, folks that unfortunately try to game the system, and so those are all things that I think could be stumbling blocks as we go forward.
So an example of gaming the system would be, just speaking in general terms, would be to show improvement in, or to show that value, to show improvement in care that isn't real. It's just an artifact of data. Or can you tell us just a little bit more about that?
Yeah, absolutely. So I think you're hitting it there. One of the things that happens frequently, for an example, is if I'm a physician and I have a templated plan for a patient, and that patient comes in on their next visit and I bring forward that template, there's times that things get recorded that may not have really even been done. Mm-hmm. And so, making sure that that those things are identified and there are policies and procedures put in place to help look at those type of things, because nobody wins if everyone tries to skip around and add more to what they're really doing.
Sure. So how does meaningful use figure into all of this then?
Well, hopefully everybody listening it has got an EHR and really has been part of meaningful use. But meaningful use really is another avenue of value-based purchasing because it focuses getting the data in a format that can be used. It focuses around quality and really helps, I think, providers move quickly to be able to handle more of a value-based purchasing world. There's been over $11.7 billion paid out, both the providers and hospitals. Stage 2, if you probably all are aware, Stage 2 begins January 14th, and the heat's getting turned up a little bit. Eligible hospitals will have 17 core measures. Eligible providers go up with their potential quality measures. An increase in the CPOE and for medication and other key areas, the addition of secure messaging. So a lot of things are moving, and I think this is probably what we're going to see for all of these programs is, the name of the game will be changed, and they've all started out with some minimal requirements, but are rapidly changing and adding more and more requirements to keep afloat there.
Right, because the whole point isn't just to adopt an EHR system as, so there's efficiencies involved, but that's not really the point. The point is to use these tools in a way that improves care.
Absolutely, and the consequences of that are that the healthcare system as a whole will be able to understand patients and be able to provide new care that's better for the patient, better for the provider, at a lower cost.
And then there's Stage 3 supposedly coming in 2016, although I know a lot of people are hoping that there will be some delay there, but that's going to move even further in that direction is my understanding.
Yes, absolutely. And there's a lot of change for healthcare. You've got ICD-10 coming, which will be very interesting, for providers understanding that, their billers to understand that, and it will really, all this stuff is really, I guess, what you call maybe the perfect storm. We just have so many changes coming from different directions that it's going to take some good leaders to be successful.
And ICD-10 is considerably more complex than ICD-9.
Absolutely.
So where is population health today, and how is it going to change in the coming years?
Well, when we talk about this value-based purchasing, the ultimate goal is really to move to more of a population health environment. And there's a massive shift going on to try to do that movement, but really it's just begun. We still, when we talk about IT, we still lack a lot of capability in the data and really moving to real-time decision support based on that data. There's a lot of work that needs to be done. And I think organizations will really have a new work environment as we move and transform healthcare to population health. There'll be new opportunities within practices. There'll be new tasks that need to be completed. And we work with several different organizations that have been doing this for a while. If you were to ask them, they really would tell you that they themselves are really in the early stages of what is to come as far as the population health. We work with our solution has a lot of population health management tools, and really moving and trying to level the playing field, not for just individuals, but for the population as a whole, is a massive undertaking.
Tell us a little bit more for those of our attendees who may not understand what you mean by population health. Just spell that out for us a little bit.
Sure. What we see in the industry is, I'm sure you've heard about a lot. There's a lot of variance in treatment and care within regions themselves. And so when we talk about population health, what we're really doing is, traditionally, let's take an HMO. They would have a disease management group, and they would really focus on maybe 1,000 of their high-cost patients, and they would try to manage their disease or their utilization, and they have different programs. What we talk about when we talk about population health is actually eliminating the disparities between all of the patients within a region or a group. So not only focusing on those high-cost patients, but focusing on the overall population. So as we move to some of the value-based purchasing, what you may see in the future is that a provider organization like an IPA or an ACO might get paid some flat rate for their whole population. And then managing that population, not only do they have to manage those high-risk patients, but they also need to manage those that aren't high-risk and really engage those patients so that in the future they don't become high-risk patients. So really population health is about leveling the playing field and not just looking at different subsets of population, but the overall population.
So there's a lot involved in this. How can providers start to get ready for value-based purchasing?
Well, if you're not already in some form or shape working with plans or CMS, it's a good idea to really start discussing this with your overall organization and the leaders within your organization now. When we had HIPAA, when we had Y2K, we all sat down and we did kind of a risk assessment for the organization. And as we move forward with this, I think this is another area of great change, and it really requires an organization to kind of sit down and do some planning and understand the implications that they may have. There's an impact on claims payment. There's legal and regulatory requirements that need to be evaluated. There's new product offerings that may be good for your organization, or new product offerings that may not be good for your organization. Obviously, there's some IT requirements to be able to do some of the things that are required, and there definitely will be an impact on staffing. So, today we do a lot of, the evolution has been from, paying for reporting and then changing kind of the paying for processing, and we're moving into this value-based purchasing to really paying for outcomes. And I know that's a very touchy area as we move forward, and so there's I think an organization needs to start planning today and be prepared, because it's just right around the corner.
All right, so that gets through we're through the main presentation now, and we have plenty of time for questions from our attendees. So I'd like to invite them to type questions into the chat area, and we'll share them with our presenter. For the first question, though, I'd like to ask about patient behavior because that's obviously a key part of this. And I think many providers are a little, maybe that's part of it that gives them some nervousness about this because I know that providers already are trying to work with patients to get them to improve their health, and patients don't always do the things that they say they're going to do. So I wonder if you could address that subject a little bit and talk about sort of the frustrations and anxieties around changing patient behavior. Because providers obviously don't have control over patients. So part of this is patient engagement. What can you tell us about this?
Sure. Well, I think overall you could say that patients really want to be part of their healthcare. And I would say, you're always, I was a firefighter and paramedic, and I dealt with a lot of folks that I probably would say would not ever change their behavior. And you're going to have those folks. But, I think providing and getting the patient involved, I think the majority of folks really want to do that, and they want to be part of the healthcare. But as of today, there's not a lot of real patient engagement. Sure, my health plan might send me a letter and say I'm due for this. Well, that's great. I might get the ability to log onto my provider's website and pay my bill. But those aren't true engagements. And I think, we've got a lot of movement in the industry on devices. And, there's a lot of fitness devices. And I think the device market is really picking up, social media. There's a lot of different avenues really to connect with patients. And everybody really wants to belong to something. And I think, being part of their own healthcare and belonging to that is key to getting them engaged. And I really say that, I think providers and organizations really need to think outside the box. It used to be that we all had a Sony Walkman. We might have a video camera and a camera, and then that crazy thing, the iPhone came out, and the iPad, and all those devices went away. We just have one. We all carry that. So I think, just like technology, folks have been innovative, I think providers need to be innovative about how they communicate with patients and how they really get them involved.
So another question, when it comes to, there's two sides to this. One is improving patient care, and another part of it is really controlling costs as well. And it seems to me that there's some tension between the two because, or at least there may be that perception, because improving patient care at least can be perceived to be expensive. So how do the two sort of marry together, and where do you see things moving as far as that goes?
Well, I think there's a lot of things. Boy, I mean, we probably could talk for hours about that alone. But if you look at some of the things that are being done, we talked a little bit about the organization's going to look a little different. There's going to be new tasks and new things to do. And, our traditional fee-for-service, obviously, if a provider wants to stay in business, he has to have patients come in. And, he has to see so many a day to get to a certain budget to keep his doors open to even provide care for patients. And as that changes, and we kind of move away from kind of a piecemeal and a fee-for-service environment, I think providers will actually have more time to spend and be able to really focus on the care more, and the payment will come. I think there's a lot of different initiatives out there that are actually showing that they can provide better care and reduce the cost. We see that all over. Some of our clients have dramatic results. I'm thinking about a very popular hospital that just did some simple things in their process and have kind of streamlined the way they do business and made it more efficient, and in the process lowered cost and increased care. So there's definitely a lot of areas that can be changed and really not only lower the cost but increase the care that's given to patients. And those are struggles. That's where I really think there's a lot of different programs. There's a lot of different innovation and ways. As an example, I think about my son had a heart murmur, and we went to the cardiologist. We got there, and they did some tests and stuff, and our primary care provider didn't even know what was done. So there's a lot of inefficiencies, And both, by the way, both those groups had great EHR systems. So, there's a lot of inefficiencies that can cut costs out and really improve quality. And sometimes it's not major things that you have to do. Sometimes an organization can make minor changes and make a huge impact.
So they both had EHR systems, but they weren't interoperable. Is that what it was?
Absolutely, absolutely. And, a part of that, we went and had an X-ray as an example, and, instead of the provider being able to call us and say, hey, it was a negative X-ray, we actually had to make an appointment and go in and see her because she doesn't get paid if she called us on the phone. So, I mean, what kind of environment is that?
Right.
She should, yeah. So.
It's obviously inefficient. Here's a question from one of our attendees. She'd like to know, how does ICD-10 figure in to pay for performance?
Well, as we move to ICD-10, obviously there's a lot more codes for you to understand, but, they're a lot more specific. And as we try to better understand where inefficiencies are and where different quality measures fit in, those ICD-10 codes will help us better identify the care that's being provided for patients. And so you're going to see changes. Like we're working with NCQA right now as we get ready for the 2014 and prepare for ICD-10. And there's major changes in NCQA and HEDIS reporting on those quality measures that really help us better identify what was done at the office.
I'm sorry, could you repeat that last bit? I think you may have broken up just a little bit. Hello, Greg, can you hear me? Oh, we seem to be experiencing some degraded audio quality. Greg, can you hear me? Greg, can you hear me?
Yes, I can.
I'm sorry, okay? we had a little glitch in the internets there. There must have been something in the pipes. We lost audio for just a moment, but it seems we're back.
Great.
All right, so we have a longer question here. Let me see if I can convey this to you. All right, I'll just read it to you. It says, I think patient involvement is actually on the decrease given the complexity and layers of care, especially given their increasing financial obligation for their care. This is especially true in lower income and less educated patient populations. If providers were interested to increase patient participation and awareness, there is no time currently given the added time needed to comply with current data entry, etc., even if that data has little to do with the current patient problem. So I don't know if that's really a question, but maybe you could address the concern that the attendee raised.
Yeah, I think that's a valid concern. Trying to, I guess there's a lot of different changes going on. You've got offices that have, these great EMR systems now, and there's a lot, maybe didn't make things easier necessarily. There's maybe even, in this case, it sounds like more documentation that needs to be done to enter that information for the patient. And I think, there is a great concern about how the cost of healthcare is creating a lot of struggles for Americans. And this year is no different with premiums on a rise of about 37% for 2013. It's continuing to grow, and the gap between those who can afford it and get it done and actually come in for wellness checks and the things that we want them to do is getting greater. And so I think that's going to be a challenge. I think though we're moving in the right direction. It may be kind of painful, kind of like pulling the Band-Aid off all at once, but we've got a lot of initiatives I think that are going to help that. And I think this is where different programs, it really starts at the grassroots view for providers and the people that work with these patients every day to really make a difference. CMS can come up with rules. We can come up with some of the greatest quality measures, but it means nothing if the folks that see these people every day don't have a way to really bring the patient in and make a difference in their lives. So I think it's a valid concern. I don't know that I have a magic button or answer for that, but definitely it's a concern. And I think that's why we, as organizations, we really need to plan and see how this is going to impact all the regulations, the changes, and how that impacts their office, and how they can take advantage of those changes instead of making it more detrimental to the survival of their office.
And this only addresses a small part of it, but I know that there is movement on the technological side as well to make data entry in the EHR systems less cumbersome. We hear this from providers quite a bit, that it's actually takes more time, and I know that there's sort of API solutions on the horizon to try to make that data collection a little bit less cumbersome to providers. But that's obviously just one piece of what the attendee is addressing there. So, Greg, you said this is a time of experimentation. Can you tell us, and obviously this is very complex, but can you tell us just a little bit about some of the more interesting experiments, or just fill us in a little bit on what's going on out there?
Sure. Well, we're working with some organizations that are doing a little bit of all different things. They've kind of been all over the board. We've got some bundled payment folks that are looking at how they can reduce that post-acute care cost for bundled payment. And what I'm really impressed with CMS about, I know there's not a lot of times that you can say you're impressed with CMS, but I am impressed with the fact that they came out with programs that allowed people really to create their own program based on their organization. So, these bundled payments, most of the organizations kind of got to pick out what they wanted to carve out and submit those things, and kind of really experiment on how they might make a difference. We have some ACOs that are trying all different types of tactics, where they're working with Medicare beneficiaries to do more engagement and bring them in. There's some that are really focused around helping the provider meet different efficiencies, and in the EHR realm, we have different EHRs that we're working with really to get information to the right people at the right time and be able to push messages in different formats. And so there's a lot of different things that are going on, both on the finance and on the engagement, and then on really helping providers be more efficient.
Here we have a basic question about ACOs. Basically, just tell us how ACOs work. ACOs, my understanding is that they were they created by the Affordable Care Act? Is that where their legislative authority comes from?
Yeah, so when we talk about CMS, yes, that is correct. Now, we have a large client base from California, and if you were to ask most of them, they really would tell you that, hey, we've been acting as an ACO for years. And on the commercial side, it's really been experimented with here and there for quite some time. So on the ACO side for CMS, it's, I don't know how much you want me to explain, but a group of physicians, it can be a hospital and physicians. There's a couple different models that are out there, but in most of the ones that we've seen, they've been physician-based and not hospital-based. They're physician groups that get assigned members based on their TIN and the polarity of service that's provided to those beneficiaries. There's been a lot of issues around beneficiary assignments and changes there, but I think we really have some strong ACOs that have started now and moving down the path. There's some quality requirements and reporting requirements. Probably the biggest challenge on the CMS side is that as an ACO, you're responsible for those patients' costs. However, unlike an HMO, you really can't control or tell the patient where they can or cannot go. So you may have a lot of patients going outside your network, and you really just have no control over the cost there. But at the end of the day, you're going to be responsible for that cost. So there are some big challenges for ACOs, and definitely I think the bigger ACO that you are, the more efficiencies that you can obtain and the easier it'll be for you. A smaller ACO is really going to have to try to do the same things that large ACOs are doing, but with a lot less resources, money, and a lot less patient volume to make some variances.
So I'm sorry, tell us just a little bit more about how, so an ACO gets paid for the care of the patient. They're sort of, I'm searching for the right term, but they're responsible for the care of the patient, but then they don't necessarily control the access of the patient to health resources. Tell us a little bit more about that, if you could.
Well, kind of, right? So an ACO is assigned beneficiaries based on the providers that work with their organization, and those beneficiaries have the right really to go on the CMS side, have the right really to go to any provider or any organization that they want to go to. You can't restrict that. What the goal then of the ACO is really to help with coordinated care. So the provider group can't say to a patient that they can't go to this provider or not, but their goal is really to focus on primary care and coordinate the care of that patient and help the patient navigate the healthcare system. And in the process of that, help lower costs. So they are paid at the end of their contract, and they'll say we're a prepayment plan, and so they have 3 years that they have to really reduce the overall cost. There's a CMS calculation that looks at the projected spend and growth of those beneficiaries. They give you a benchmark for those costs for those beneficiaries, and your goal is really to lower that cost and share in whatever is saved with that. And there's a lot of regulations, and I could probably go on and on about the formula and how that's calculated, but the ultimate goal is to really to reduce the overall cost for that group of patients and increase the care. There's quality, both measures to look at. There are also patient satisfaction that they have to meet, and all that gets calculated into their payment or that shared savings at the end of the period that they have. And so one of the challenges is that from day one, ACOs really need to understand the risk of their population so that they can implement programs. They need to understand the variation between the doctors that provide care within their ACO and help those doctors look at better efficiencies and different ways that they can help lower costs and coordinate the care better. So there's a lot of effort that has to be up front, and really understanding the data is key. There's no way an ACO can move forward without really understanding their population and understanding the risk and where that risk is going, along with how their providers are providing the care to those patients.
So there's a lot of complexity involved and kind of an increase in effort in some ways, but there's also incentives, considerable incentives as well. Isn't that correct?
Absolutely. So if a group, does well with their shared savings, there are some very good incentives and payments that they could receive off there from their shared savings. So there is, a lot of reward. Eventually, there will also be the other side of that, and so, I think that's why getting in and really getting, if you're an ACO and you're starting out, what we saw with a lot of ACOs is they really weren't sure where, they had ideas of what they want to do. They may have a strong medical director or they may not, and really getting in to analyze data, because the clock ticks pretty quick. This year, it's paid for reporting, so you just needed a test that you can report on different measures and monitor that. Next year, you actually start getting paid based on the performance. So, the clock is ticking, and I think at the, in 3 years here, we're going to see how well some did, and I think some will do well and some won't do well.
So you spoke before about that we're kind of in a time of a perfect storm with healthcare, with so many different changes in so many different areas. So there's meaningful use, incentivizing providers to adopt EHR, there's ICD-10 on the horizon, and then there's value-based purchasing. What would you say to a provider who just says that they're overwhelmed by the pace of change? What are some simple things? Well, none of this is simple, but what would your advice be to them in terms of just getting down to grappling with this change. You mentioned before some of the planning steps that are involved. Maybe you could tell us a little bit more about that.
I think I think you really have to do kind of a readiness assessment, and there's some things that you just can't stop, like ICD-10's coming, sequester does not happen. There's things and regulations that are happening that ready or not, they're coming, and you're just going to have to take the bull by the horns on some of those things. But I think just like we did with HIPAA and just like we did with Y2K is as an organization, an organization needs to identify who can be the leaders in that organization to help drive that organization to navigate some of these changes that are coming in. And I think taking it in pieces is probably the best way to do that. If you haven't gotten in the HR system yet, you need to think about doing that pretty soon. Time's running out. We had the carrot, the stick is coming, and so I think and plus you're losing out on funds that you might be able to get. So I think taking it in chunks. Yes, there's some regulations that are coming, and I think physicians and providers traditionally have been great leaders, and I would expect that we're going to see some great leadership with organizations, and I don't think that it's a lot of change, but I don't think it's not attainable. And I definitely have met some groups that have done some amazing different things, and so I think yes, it's frustrating, and yes, margins are getting smaller and things are changing, and it's going to get very hectic here over the next 3 years as we move to ICD-10. And do I have my billers? Can they handle that? Do they know all of that? Now there's just lots of concerns, but planning always helps. And I think doing kind of a readiness assessment of all the different changes that are coming, and actually your organization should have a chart that says, here's when these go into effect. Here's when we need to review those. If we need to talk about them, we just need to be prepared. And really, someone in your organization has to be a leader and say, we may not like them, they're coming, but we're going to deal with them and we're going to take them on. And I think without that type of leadership, you'll have a rocky road. But I think that's what it takes, is planning and leadership.
Well, we're nearly out of time, but before we conclude, maybe you could tell us just a little bit about your organization, Greg, MZI Healthcare.
Sure. Well, MZI has really been in business for over 25 years. We really started software around the payer side. So we have over 20 million patients that run through our system. Our clients are IPAs, MSOs, and TPAs that manage HMO business, and they process claims and benefits for some of the large carriers. Some are small health plans, and we have a care management software that works with disease utilization and complex case management. So if you have nurse navigators or nurses that need an application to manage plans and treatment plans, care plans, we have that type of software. And then our third software is our analytic tool, which is a cloud-based big data solution that works with both financial and clinical information into one data repository. Lets you look at risk, lets you manage bundled payments, lets you look at over 500 quality measures from NCQA and P4P. It looks at provider profiling so you can understand where discrepancies might be and where providers may need help or where providers are performing outstanding. So we have tools that really help hospitals, payers, and providers to kind of navigate some of the healthcare reform that's out there today.
Well, thank you, Greg. I want to remind our attendees that we're going to assemble all of the audience questions and post the answers on our site with links delivered via email later in the week. Remember that all registered attendees will receive an email with links to both recorded and PDF versions of this session. I want to thank you, Greg, for joining us for today's Learning Lunch. I thought this is very informative.
Thank you all, and I hope you have a great week.
There's so much, as I was saying before, there's so much discussion of value-based purchasing, and to have an expert guide us through it was really helpful to me, and I hope it was helpful to our attendees as well. I just want to remind our attendees that to learn more about our industry expert, Greg Gootee, and MZI Healthcare, please visit www.mzihc.com. Thank you to all of our attendees for joining us for today's Learning Lunch. Be sure to join us for our upcoming Learning Lunches by visiting our homepage at formetapproved.com. Simply click on the button near the bottom of the page to register for upcoming Learning Lunches and learn more about them. Our next Learning Lunch will air on Tuesday, May 28th, and we'll cover the subject of patient engagement strategies, which dovetails nicely with our discussion today. Keep an eye on your email box on our homepage for other upcoming topics, and thank you again to everyone for joining us today.